And now we move to the second part of the session, which includes case presentation. It gives me great pleasure to introduce my dear friend and colleague, Professor Dr. Ayman elsamadoni, and the case presentation is entitled "Do Not Underestimate the Power of Remodeling when Using TEVAR in Treatment of Type B Dissection."
Thank you very much. Thank you, Mr. Chairman. Thank you to Sharif for introduction. The idea is you have to follow the secondary. It's the problem of the secondary tears in patients with TEVAR. That's the case of descending thoracic aortic aneurysm complicating a subacute aortic dissection with significant right common iliac artery secondary tear with a static malperfusion of the right kidney with really an unexpected outcome. The patient we have is a late 40. He's recently discovered to be hypertensive, presented with an epigastric pain, which has been mistreated for gastritis. Later on, he developed dyspnea on lying flat. So he had an echocardiography that showed compression of the right atrium. So he ordered a CT angiography, and as you can see, the flap started a little bit above the celiac, to the mid-thoracic segment with a primary tear and another secondary tear, and just I'll show you how. That's our diagram of the dissection where it starts. Our primary one was around 3.1 centimeter from the celiac artery with a width of about 2.8 centimeter with a false aneurysm, and then another secondary tear here at the distal right common iliac artery, perfusing the right kidney with a static malperfusion. Thank you. And that's here. It's another picture of the static malperfusion. You can see the intima thrown into the right renal artery. Our strategy will have a left brachial axis, left femoral cut down for the device. We choose a Gore tag device 40 by 40 by 150. We had the right femoral percutaneous with 6 French axis. The plan is cannulation and filtration to the right renal artery, and then device positioning flush with the celiac artery, covered stent 6 mm for the right renal artery, and another covered stent for the right common iliac artery. What we had, and that's the initial angiogram, and you can appreciate much the primary tear here. And then we negotiated the right common iliac. It was taken some time to negotiate the true lumen from the false lumen at the right common iliac artery. And then we cannulated the right renal artery, as you can see here, okay, through the static malperfusion. And then we deployed our stent, as you can see, flush with the celiac artery. And we tried over and over again, try to trail a device across our wire through the right renal artery, but we did fail. We used a long sheath, we used a renal double curve, we even used a trailblazer, and nothing did pass. So, after many devices over and over again, so we chose to abort the procedure at that time. It took us about 1 hour to negotiate through the right renal artery, and we planned for 3 weeks procedure after appropriate tools, which is the microcatheter and so. So the most operative, the patient was put for tight control of blood pressure. He had slightly temporary rise of serum creatinine, but goes off in 3 days, and discharged with a planned procedure in 2 weeks' time. However, our patient kept his follow-up for 9 months, and then he presented for a follow-up just to see what's going on. He had controlled blood pressure, no more dyspnea. He has a good renal functions, so we ordered him a follow-up CT. And my expectation actually when I ordered it, either I have a progression of malperfusion with loss of the right kidney and the left kidney is the one taking the job, or expansion of the infrarenal aortic aneurysm. But that's what happened. I'll be in more details. We have a closer look. That's analysis at the main entry site. We have closure of the main entry site and no more dissection. We have no more filling or false distension. That's the pre, and you can see, I appreciate the celiac artery is, the true lumen is actually compressed, but here there is expansion of the true lumen, and there is some flow in the false lumen just at the celiac artery. Further down, can see perfusion of the right renal artery from seemingly a rounded false lumen channel to the right renal artery with still expansion of the true lumen. And then lower down, we still have this rounded channel-like and with complete roundness of the true lumen. So the patient had a reduction of its total aortic diameter, a false lumen-like channel arising from the right iliac artery to the right renal artery with some flow in the suprarenal segment, but not affecting the total aortic diameter. So we end up by aneurysm shrinkage, expansion of the true lumen, naturally induced tube-like channel resembling an ileorenal bypass, and the patient was scheduled for tight follow-up, watching for further, maybe further positive remodeling. And thank you very much.